Hello and welcome to the Point Blank Show. My name is Abhishek. Our guest today is Dr. Theodore Schwartz, among America's top neurosurgeons. He's the author of Grey Matters, a biography of brain surgery, a book that gets to the very core of this incredible organ. From the history of the brain to the evolution of neurosurgery and the life of a surgeon, Dr. Schwartz takes us on a fascinating journey. Thank you, Dr. Schwartz, for joining on this podcast.
Yeah, I'm so glad to be here, Abhishek. Thank you for having me.
Thanks. Let's start with the very early days. And I couldn't help but have a feeling when I read your book where you talk a little bit about your childhood as well as what you did in high school. I thought you were embarrassingly good at quite a few things. You played football in high school. You were part of the team. You played, I think you started with piano and saxophone. And before we started recording, you said you still play the bass guitar. And then you graduated from college with degrees in philosophy and English from Harvard. So it's a lot.
Yeah, it probably sounds more impressive than it is. I think most of the people who played football with me would not remember me as the most outstanding football player on the team, but I showed up every day and I worked as hard as I could, and I did my best with whatever talents I was given. And I was lucky enough to get into Harvard, I think mostly because I grew up in an environment with a father who was very intellectual and constantly asking me questions, and we listened to a lot of classical music, and he'd take me to foreign films, and we didn't watch a lot of sports in my house. I had to pick that up on my own. So I think that unique upbringing helped foster an inquisitiveness in me that probably helped me focus a little more on school and really enjoy my schoolwork, which kind of propelled me into an academic career.
How were the dinner conversations on the dining table with your mom, dad, when growing up? Was it very Freud and the like, or?
Yeah, it was pretty much. My father would spend his weekends basically rereading the collected volumes of Shakespeare, the plays of Shakespeare. He would reread Freud every summer, the collected works of Freud. He would listen to opera all day long in the house while he was reading. And I think that he was such an imposing, intimidating intellectual character that when I went to college, my goal was to challenge him. So I would take all the courses I possibly could that were critical of Freud, whether it was feminist philosophy or some other type of philosophy, a lot of deconstructionist, structuralist philosophy, literary criticism that would use Freud to, analyze texts. That was sort of my goal. And so I would bring that all back to the dinner table. And I would try to raise these criticisms of Freud's theories. And he always had great defenses because he was a professor himself. In a way, he taught at the New York Psychoanalytic Institute. He taught the interpretation of dream course. And one of my favorite things to do is to go to foreign films or any film with my father, because he would walk out of the movie theater with incredible interpretations of what was going on. He would always see sort of the latent, hidden meaning that was working its way through a film that wasn't always apparent on the surface. And he opened my eyes to that very often there's a lot going on beneath the surface that we hide from ourselves. And I think that's very true of how the brain works, that the brain is really working to the majority of the degree like a submerged iceberg beneath the surface when we have no real clue as to what's going on. And our personalities, our egos, ourselves are really just the very, very tip of the iceberg.
And the human brain, while you are an expert on the subject, I'm on the other end. But even as a layperson, I find it fascinating. You just gave out a little bit of it. And I read this in a book by Bill Bryson on the human body. He's got a chapter on brain. And it said, just sitting there quietly doing nothing at all, your brain churns out more information in 30 seconds than the Hubble telescope has produced in 30 years. And there is an endless stream of trivia about the human brain. But as somebody has no direct academic background remotely associated with that organ, it fascinates me that it just sits there silently, unlike a heart that pumps blood, lungs inflate, deflate. This thing has no feelings, no pain receptors. This is my perception. How did you first get introduced to it? And when did you decide that, hey, this is something that I'd like to do for the rest of my life?
So I, in college, studied philosophy and English, and I was interested in language and how we create the world around us through language. And I did have a bit of an interest in neuroscience because I started studying a field called neurophilosophy that tries to combine philosophy with neuroscience to try to understand how our senses, our natural senses, create the world around us and the interplay between neuroscience and philosophy. But when I went to medical school, I was not at all thinking about brain surgery or neurosurgery. Neurology was a possibility. Psychiatry was a possibility. My father was a Freudian psychoanalyst, as I mentioned. And then I think the moment I walked into a neurosurgery operating room, and the reason I did that, we had an anatomy preceptor. The first time I was exposed to neurosurgery, there was a woman who was a neurosurgery resident who was teaching a course on neuroanatomy. And she gave a little vignette. She was teaching us about where the third nerve is that controls the pupil, teaching us the anatomy. And she says, hey, you're in the emergency room. And a little girl rolls into the emergency room. She's been hit in the head. And you examine her eyes and her right pupil is dilating. And you need to make a decision right now. What is going on and how do you save her life? And the answer was that the reason the pupil was dilating was there was a blood clot pushing on the brain. The brain was pushing on the nerve that dilates the pupil. And because you had studied neuroanatomy, you knew that that was what was going on. And the answer was that you immediately drill a hole in her head and suck out the blood clot. And you can save her life. And after studying philosophy for years and years, cooped up in libraries and staring at books and worrying about things that very few people really care about, honestly, the concept that you could learn stuff that would allow you to save someone's life in an instant was a remarkable thought to me. And I was intrigued at that point and decided I wanted to learn more about neurosurgery. So I did a rotation in neurosurgery. And I'll never forget walking into the operating room and seeing the human brain exposed and seeing a surgeon who was working under a microscope because, they have to work at a scale that's very different than the scale of the world that we live in. We live in a world that's measured by feet and inches. And neurosurgeons work in a scale really that's measured in millimeters and microns. It's a very small world that they work in. And so you need a microscope to take you there. And I had also, my other passion when I was growing up was astronomy and astrophysics and how the universe was created. And so I always imagined myself being an astronaut when I was a kid and traveling to, other places and fantastic worlds that very few people get to go through and using science to get me there. And I saw these neurosurgeons basically sitting in these motorized chairs that were holding their arms in front of them to reduce their tremor, looking through these microscopes that essentially looked like, spaceship observer ports and traveling down into the depths of the brain, which is this cosmic unknown microcosm of the world. And I was smitten when I saw it. I mean, the minute I saw it, I was like, this is incredible that they get to do this every day and train their bodies to do it, which to me reminded me of the music we spoke about, the idea of practicing moving your hands and moving your fingers in a particular way to teach yourself, how to play a piece. There was the same technical expertise you had to acquire to become a brain surgeon. And so I put it all together, my interest in the mind and the brain and philosophy and working with technology to travel places that few people get to go and working with my hands and a performance, which a brain surgery operation is very much like a performance. From start to finish, you have to execute it perfectly. There's improvisation that has to occur, and I was a jazz musician, so I like improvisation. You get, trapped in certain areas, and you have to figure out how to get out of those jams that you're in order to help someone else. So all of that came together when I experienced neurosurgery and really made me fall in love with the field.
Yeah, but it's not really for the faint-hearted, is it? You've written about it in the book when it comes to training. The romance of it is wonderful, but it's grueling, frustrating. I've read of stories of 100-hour weeks. You'll have to help me with it. Folks actually down Red Bulls at 2 a.m. just to stay up. Give me a little bit of a sense of what was it to be a resident and a student back when you did this.
So when I trained in neurosurgery, we did not have work hour restrictions that they have now. In the United States right now, residents are not allowed to work more than 88 hours a week. We think of a 40-hour work week. Neurosurgery residents now are limited to 88 hours. And that was a limitation that had to be put because I was working far more than that. So you would work a full day. You'd get in the hospital about 5 a.m. because you had to pre-round on the patients before the OR and make sure everybody was okay. And then you'd work a full day, and maybe you'd leave the hospital at 7, 8 p.m. But if you're on call, you stay in the hospital all night long, and you work all night long. And you might sleep an hour or two if you're lucky, but you're getting constantly paged and woken up, and you have to go down and take care of patients. Their IVs would fall out. They need CAT scans. They need evaluations. The nurses would call you to order medicines on them. So you're basically up all night, and then the next day would come, and you wouldn't go home. You'd actually work the whole next day as well. So we'd do 36 hours straight. And then we get one night off and then we do a full 12-hour day and another 12-hour day, and then we do another 36 hours straight. So every 3 nights we'd be working 36 hours in a row, and we never got a day off. We would just have the night off to catch up on your sleep. So it was really brutal training, and it was not just physically brutal because of sleep deprivation, but it's also emotionally brutal, right? You're seeing patients who are very, very sick, who require you to make decisions instantly to try to save their lives. You're dealing with their families who are obviously distraught. People who come into the emergency room with an accident and they get hit in the head or they're in a coma. They don't know if they're going to wake up or not. So there's a whole psychological, emotional component to dealing with those sorts of tragedies on a daily basis. And then doing it when you're sleep deprived is even harder. And I write in the book about the hardest part. We think the hard part is making decisions. Like making decisions when you're sleep deprived, we want our doctors to be able to make thoughtful decisions. And how can you do that when you're sleep deprived? But what I found was more challenging when you're sleep deprived is to be sensitive to another human being's suffering, to find that caring, to find the empathy within you when you're feeling so sorry for yourself because you're so exhausted and you don't have the energy to draw upon that. Making the decision as to what to do is not that difficult if you've been in the situation before, and there's always backup. But what's very hard, I think, is being a sensitive, empathic human being when you're sleep deprived and angry and frustrated. And that's such an important part about being a good doctor. And I think that's what the overworked hours tends to diminish in physicians, really, is that sense of empathy.
Is that taught at all, whether to neurosurgeons or in medical schools, how to deal with a patient especially when the case is terminal, your scalpel won't work, the most important tool will be your words?
Yeah.
Is that something that is covered at all?
When I trained in medicine, there was a start of that. We had a course called the patient-doctor relationship, and they did try to teach empathy. But, I think to a large degree, it's something that you either have or you don't have. It's how you're raised. It's what kind of human being you are. And you certainly can work on it and you can get somewhat better at it. But it is hard to teach someone how to be a good person, how to do the right thing.
And if I were to ask you, Doctor, how did you keep your wits about yourself with that kind of a punishing schedule when nobody really cared about what you were going through? Because obviously people look up to you to solve a problem in their family and nobody cared. I'm sure your colleagues would be in the same boat. So how did you guys manage that? And what was your escape route, if at all there was one?
So one route was, there's this band of brothers phenomena that happens. You sort of think about it in the military. I had a co-resident who became my dear friend, and we were going through it together. So we would go work out when we had a chance, and exercise, which was a great way to, let off steam. We wrote a screenplay together, the two of us. So we would talk to each other, and in our fantasy world, we had this screenplay we were going to write. And we just spent a lot of time together supporting each other. And that was really important because the residents above you and the residents below you, you have a very different relationship with them because that's also very hierarchical. So we didn't get along as well with the residents above us. We got along very well with the residents below us, but we got along particularly well with each other. And then I also trained in Manhattan, which was great, in New York City, and all my friends and family were there. It's where I'd grown up. So I was able to see people that I knew on the weekends and maintain those connections.
And for someone who knew what you were signing up for, you didn't stop after 4 years of medical school and 7 years of residency. You didn't start your practice. You went another year to Munich, was it, to learn more on the subject?
Yeah, so I did a fellowship. Half of it was a research fellowship, half was a surgery fellowship. And many neurosurgeons do fellowship training where they go on for another year because there's an enormous amount of information that we have to learn and types of surgeries we have to learn how to do. And when you train at a particular neurosurgery program, there may be, if you're doing brain surgery, there may be 3 or 4 people there doing brain surgery that you're training with. So you're really only learning how to do what 3 or 4 people know how to do. And they learned it from a limited number of people. But there are other people doing things very differently around the country. And you don't always see all the pathology or all the approaches, all the types of tumors you might take out, all the different ways of taking it out in your training. Even though it's a 7-year training, you still don't learn everything. And so many people will go on and do an extra year of training, go to a different institution, learn from someone else. And I ran a fellowship for many years and had residents who trained under me, which is very rewarding. And I too trained. I went to Yale actually for 6 months, trained there, and then I went to Munich, Germany, just to do basic science research through a fellowship that was called the Van Wagenen Fellowship in neurosurgery, and learned at the time I was doing epilepsy research. So I worked in a basic science laboratory full time, and then started my own laboratory so I could continue that research on my own.
And at the beginning, did you find any of that intimidating? Long hours, you have to sit or stand in a particular position, so you need stamina. Obviously, the precision, where you talked about how you only have centimeters to work with, and empathy to break bad news. You have to be calm under pressure. It's the whole package. So,
Yeah.
in those early days, what was going through your mind? Did you know that you were cut out for this, or did you have doubts?
No, I mean, it's very intimidating. You speak about imposter syndrome. Everyone talks about imposter syndrome. When you start your training, you have no idea if you're going to be good at this or not. And the thing is, many of the operations, the complex ones, you don't even start to learn how to do until you're 6 years in, 6 years into your training. And even 7 years in. And so, at that point, you're 31, 32 years old. You could find out, at that age that you're not very good at this job, which would be scary. And it's overwhelming. It's terrifying. The decision to become a neurosurgeon I found very difficult to make, because the reputation is one where you essentially give up your whole life. You work full time in the hospital. Anything, other interests that you had, music, sports, etc., fall by the wayside. There's a high divorce rate among brain surgeons because of the work hours. And so all of that was very intimidating and scary. But at some point you have to make a leap of faith. And I think what I realized was I saw doctors in other fields where I was, and I was at Harvard Medical School at the time, and I remember leaving the hospital at like 9 p.m., and I saw the internists and the gastroenterologists leaving the hospital at 9 p.m. because they were so dedicated and they wanted to do the best for their patients, and they were working really hard also. And I said to myself, it seems like no matter what field I go into medicine, if I want to be the best, I'm going to be working really, really hard, so I might as well do the thing I want to do. That I'm most passionate about, because then at least if I'm working really hard, I'm working at something that I am very, very committed and passionate about. So that helped me make the decision about neurosurgery, because I realized that all doctors work really, really hard if you want to be really good at it. And this was the thing that really got me the most excited. It was the one rotation where I was never bored. I was always excited to be there. Everything I saw was another miracle day after day. And so that just seemed like a great way to spend a career.
So take us inside the human brain, the steps that you might have to take to see that object. And do you remember the first time? Obviously you would, when it presented itself to you, which nobody but neurosurgeons can get to experience. So could you take us through the steps? What happens to the skull and how do you get in?
Yeah. So I don't want to get too gruesome. There may be some listeners who are squeamish, but these surgeries, about 95% are done with patients asleep under general anesthesia, and a small percentage are done with patients awake. But when we have them awake, they're actually asleep for the beginning part where we're opening, and then we wake them up in the middle. So they give a lot of local anesthesia so they don't feel anything. But as you imagine, you have to first cut through the skin. Some people shave a little bit of hair, and we try to make all our incisions behind the hairline so that you don't see them. I mean, you can shave a little hair, you can not shave hair. It's sort of your decision. And then the skin is the scalp in particular is very vascular. There's a very robust blood supply. So we have clips that we put on the skin. They look like clips that keep large reams of paper held together that clamp down. And so we can clamp these clamps around the skin very quickly in order to stop the bleeding. And that allows us to open the skin. And then you're looking essentially at the skull, which is white. And there's also muscle. The muscles for chewing on the side of the head are pretty big muscles. And we also often have to cut through those. So once you cut through the muscle, then you have to drill holes in the skull. And we use, power drills to drill holes down to the dura, which is the covering of the brain, which is white. It's a very thick skin over the brain, so that makes it safe for us to drill holes in the brain without damaging drill holes in the skull, without damaging the brain. And then once you drill a hole, you then have a power saw that is a side cutting saw that you can then use to make a circular cut, or a square cut, or whatever size you need that will expose the amount of brain you need to expose to do the operation you need to do. And one of the most common openings we do is called a pterional craniotomy, because this part of the skull right next to the eye is called the pterion. And so often we make an opening right here because that allows us to access not only the side of the brain, but allows us to go under the brain. and do a lot of work. And in the last 20, 25 years, we've started doing a lot more surgery through the face. And this is one thing I write a lot about in the book, is that we can now do surgeries where we go up through the nostrils. We don't make any incisions whatsoever. We just put long endoscopes up through the nose and can get to the base of the brain. We can make little incisions in the eyebrow. We can even make incisions in the eyelid and work around the eye in order to get to different parts of the brain. And in those situations, we'd work with ENT surgeons or oculoplastic eye surgeons to help us get where we need to get these very delicate areas that can be hard to reach. Most neurosurgical operations last about 4 hours, and then, the patient wakes up, stays in the hospital 2-3 nights, and goes home. So most neurosurgeons will do 2 operations a day if you're a brain surgeon. If you're operating on the spine, it's you can do 3 operations a day. Some of them are a little shorter, some of them are much longer. It just depends on the operation.
And the procedure that you just described about going through the nostril to find the malady inside the brain and take it out. When you first did this, you were, I think, 4 years you're 4 years into your profession, and that was quite a novel thing to do. And you described the case of a patient who you choose to call as Mrs. X, and that was a bit of a landmark operation for you in your personal life, as well as the unconventional technique that you had to take to get there.
Yeah, so it turns out I was one of the first. I wasn't the first. I was one of the first, particularly in the United States, neurosurgeons to start working through the nose with endoscopes. There was a group in Italy that had been doing it for a while, and other people, around the world, and some in the United States as well. And I found a great collaborator in an ENT surgeon named Vijay Anand, and we started working together. When I trained to do surgery, the concept of going through the nose deep into the brain was really forbidden, because the thought was that you'd cause an infection, because the nose has bacteria in it and the brain is sterile. And so we would go under the lip to take out certain types of tumors that would hang down in the back of the nose, but we really wouldn't go far into the brain through the nose at all. I never learned how to do that, and it was something that was frowned upon and dangerous. And a few of us figured out that it was doable. There was a way to do it, and it was very important. Not only could you do it, but one of the most important things was to figure out how do you close the connection that you make between the nose and the brain, because that's really where the problems would arise. Because if the bacteria from the nose can get into the brain, the patient will get meningitis and get very, very sick and potentially die. So we had to work on those closure techniques. But once we worked that out, and once we had all the equipment we needed to go up through the nostrils with endoscopes, you need very long, thin instruments, we realized we could go deeper and deeper into the brain. And so this particular case was a woman with a very big tumor essentially in the center of her brain. And she had gotten a couple opinions from other neurosurgeons around the country who had said, you need to open up the head and do a craniotomy, open up the skull, or you can't take this tumor out. It's too dangerous to take it out. You should just do a biopsy and put some radioactive liquid in it. That's the best you can do. And I saw her, and I had already done similar tumors, but nowhere near as big, going through the nose. And I said, you know what, I think I can take this out without making any incisions, go up through your nostrils, and the goal will be to get the whole thing out and to cure you. And she was shocked that I gave her that opinion, because no one else had told her that. And I was, again, 4 years out of my fellowship. And she went back to one of the other surgeons she had seen and said, how come you didn't offer me this treatment through the nose? And he said to her, literally, whatever you do not let Dr. Schwartz take this tumor out through your nose, as if it was just way too dangerous. So she came back to me, and I was terrified because, God forbid something went wrong. Obviously, I was out on a limb a little bit, doing something that most neurosurgeons wouldn't do. It turns out the surgery went beautifully. We took the whole tumor out. She was cured. The tumor never has recurred, and she made a great recovery. So she did very well, and that gave me the encouragement at that moment in time to go on and to continue to do this. I've literally done thousands of these operations and written several textbooks and hundreds of papers and lectured around the world and taught, dozens of other neurosurgeons how to do these operations. But at some point you had to do it for the first time in bigger and bigger tumors, and taking on that risk is terrifying, because obviously, the biggest concern is you have another human being's life in your hands, and they're trusting you and your judgment. And so you have to have a lot of self-reliance and courage to do these types of things when people around you who are more senior than you are saying, hey, this probably is not the right way to do it. This is dangerous. You shouldn't be doing this. And now, of course, everybody's doing it. So it's a nice feeling to know that you've contributed a little bit to the progress of the field. And again, I'm not the only one. There's others of us doing this type of thing. So I don't want to take too much credit for it, but I certainly was one of the early ones and someone who helped promote it.
Where does this humility come from? At the beginning, you said you were lucky enough to get into Harvard School. Now, you, of course, are crediting everyone's doing it, but you are among the first few. And you write a bit about it, that it's important to be humble. At the same time, you need to be arrogant enough to think that you can solve a case as complicated as that. These are two dichotomous qualities. Should every neurosurgeon have that?
Instead of arrogance, I like to think of it as confidence. Arrogance is sort of too much confidence, overconfidence, and I think that gets you into trouble. But I think most good neurosurgeons have a sense of humility, because you also very much need to know what your limits are, right? Because if you're constantly pushing past your limits, then you're going to hurt people, and that's what we want to avoid more than anything. So I think humility to know what you can't do, because there's some point, even in the middle, even at every operation, not just the decision whether to operate or not, because that's the first area where you have to have a certain amount of humility, because, we have other treatments for tumors. We can't, it's not just taking them out. Some of them we send for radiation. And if you see a tumor that's going to be very risky to take it out, you may decide, it'd be safer if I treat this with radiation and not with surgery. And that takes a certain amount of humility. When you're doing an operation, our goal, of course, is to make the MRI scan look perfect. We want to take out the whole tumor. We want, post-operatively for someone to look at the MRI and say, wow, the tumor's gone. What an incredible job this person did. But it turns out that when you're in the middle of an operation, you may get to a point in that operation where there's a piece of the tumor that's very stuck to a nerve or an artery. And as much as for your own ego gratification you want to take the whole tumor out, there are some maneuvers in dissecting that tumor off that nerve that has a high risk of damaging the nerve or a high risk of damaging an artery. And that may be irreversible. And so sometimes what you need to do is know when to stop and when to leave a piece of tumor behind, and when to say, the safest thing for me to do is not to do sort of the perfect operation and take everything out, but to stop and leave a little bit behind, and maybe we can treat that with radiation or just observe it, and maybe it'll grow very slowly. So that takes humility as well. So it is a careful balance at every moment between confidence and humility, knowing what you can do and what you can't do.
And is it a very physical experience as well, when you sit there and you're looking through the scope with, only a few, it's the size of a coin. That's the area that you might be operating on. So is it, does your heart rate, let's say, increase if things go wrong? And how do you deal with those moments where you have to be, these are the next 3 minutes are going to be too critical. So just take us into the operating room. How do you manage physically to hold yourself together to get those things out?
Yeah, so there's two aspects of that physicality. One is physical and the other is emotional, really. The physical aspects are real, and I do a lot of core body work when I exercise, because when I started doing neurosurgery, I would get excruciating back pain standing up for hours after hours. My body just couldn't tolerate it, and I was young. I was in my early 20s at the time, and I had horrible back pain from standing up. That has, for the most part, gone away because I've spent the last 35 years training my core and doing more sit-ups and back exercises, and also just doing surgeries more and more. You strengthen whatever muscles it is that keep you erect. The physicality of microsurgery, in that you're sitting in a chair, so it's not as much your back, but we all have a physiologic tremor in our hands. Some people have a big tremor, some people have a small tremor, but there's always something. And you have to learn how to control your tremor. And a lot of that has to do with bracing your hands either on something that's very stable. It could be the skull. It could be a metal bar that you set up. Also, when you're doing the most delicate of maneuvers, I'll often hold my breath for that period of time, almost like a sniper, who's taking a shot. They kind of hold their breath when they should. We do the same thing. You control your breathing very carefully and hold your breath so that you don't have a tremor. When all of a sudden, let's say an artery is damaged and it ruptures and blood starts to flood the field, and then you can't see anything because the blood will very quickly well up and cover all the anatomy that you just dissected, you can start to panic and you can start to get nervous, particularly if, let's say, the suction that you're using to evacuate the blood could get clogged at that moment, and then you have no suction, and then the blood is just welling up, and you have to hand your suction to the nurse who's got to replace it and clean it, and the blood's welling up more and more, and then you get the suction in, it may be too small a suction, and now you need a bigger suction, so you have to exchange it for another suction. And all that time there's bleeding and bleeding and bleeding, and you can't see what's going on because it's everything that you want to look at is submerged in a pool of red. And then your heart rate can go up. because you get nervous. What if I can't control this bleeding? And if your heart rate goes up, your tremor gets worse. Automatically, your tremor gets worse. Right. And your decision making gets worse, right? Because you're not thinking clearly. And then you realize that your tremor is worse and that you're anxious, and that snowballs, right? Because then you get even more anxious because you realize now you have a bad tremor and you're not going to be able to physically do what you need to do. So that's a moment where you have to take a deep breath and you have to calm yourself and you have to focus yourself in the moment, and you can't think about what if, and you can't think about if I can't get control, then this person will be damaged. Then you can't be thinking about the future. You just have to be completely focused in the moment, in the task, in what you have to do. So it's kind of the ultimate in mindful meditation, being in the operating room at that moment, because you have to be completely present and not thinking about the past and what happened last time, not thinking about the future, what if something goes wrong, but just the here and now.
And athletes talk about this often, where when they are in the zone on the cricket field or baseball or whatever sport you play, you can't seem to... Do you get that as well in the operating room? And do you know when you are in the zone? How often does that happen?
It happens all the time. I think when you're in the zone, you don't know that you're in the zone in a way because you're in the zone. And so the way I think of it is there are some operations where I start the operation and then you're just sort of going. And then the next thing you know, it's 2 hours later, and 80% of the tumor's gone, and you sort of wake up and you're like, oh, what time is it?
Right.
You sort of look at the clock for the first time and you realize that all this time has passed and you've accomplished so much. And then you sort of are outside of yourself thinking, oh, look what I did. Or look what time it is. Or, and then you kind of get back in there and do what you need to do. But we do get in these flow states where, our hands are sort of moving. The instruments are part of our hands because we've been working with them for so long. And you're working with your scrub tech and your assistant, and things are just happening. They're just,
right.
Your brain is controlling your hands and your behaviors in a way that you're not always that conscious of. And then if you're with a trainee, you're often describing to them what you've been doing. So there's sort of you can make a commentary almost like you're watching yourself, and then you're telling them what you did and why you did it as an observer so that you can teach.
And how important is the night before that operation that you have to do? How do you prepare yourself? If you could walk us through the hours before, a complicated one perhaps, where you really need to rehearse certain things. How does that work?
I will often wake up at 4 in the morning, 3 in the morning, thinking about operations that I'm doing. And I go to sleep mentally rehearsing them, each step in my mind beforehand, because there are certain critical points where I'm going to see this, and then I'm going to see this, and then I want to see this. And, there's an order of the things you want to expose in a different sequence, and you're trying to imagine those and the maneuvers that will get you there. And so you're replaying the surgery in your head. It's not replaying, you're pre-playing it, I would say. Sometimes if it's something that I haven't done in a very long time, I will actually, the night before, look up the anatomy and just refresh myself if it's something that maybe I did 2 years ago, 3 years ago. Because you have to understand there's some places in the brain and types of operations that we do very infrequently, because the problems arise in those locations very uncommonly. And so you don't find yourself doing it all the time. And if you haven't done it in a year or two, it's often helpful to refresh your memory and review the anatomy and review the approaches. And so occasionally I'll do that as well. But the more senior you get, the less you have to do that, because you've just seen more and more over time and you're so much more comfortable with so many different options. And I'm literally replaying in my head the timestamps of the images that I want to see as a natural course of going through the operation, almost like checkboxes that I need to check throughout the course of the operation. And until I see those, I'm thinking about them. So like as I'm setting up the operation, even the way I position the patient, I'm positioning their head in such a way so that I'm imagining what the anatomy is that I'm going to encounter when I open their head, and I have to position them so that everything is in the proper orientation for when I'm under the microscope. And that positioning at the very beginning is incredibly important. So a lot of what we do has to do with taking an image, a two-dimensional image from an MRI scan, turning it into a three-dimensional image in your brain about what you're going to see, and then being able to manipulate that 3D image and rotate it in your head so you can see it from different angles to figure out what the best angle of approach is and the safest angle of approach to get the tumor out.
It makes me wonder what you are when you're not in the operating room, because the kind of precision that a neurosurgeon needs and the kind of planning and preparation that goes. Are you a stickler where you will tie your shoelaces just so, or will, let's say, playing with your kids a game of chess or whatever, if they play, if they do something which is not supposed to be done, placing a particular chess piece in the middle of the box just as it should be, is that how you are, or how is it?
I try to control those impulses outside the operating room because I don't think they necessarily make you a good parent or a good husband or a good friend. I've learned, my wife has helped me tremendously to become very tolerant and understanding, and to realize that there are many ways to do things. Only in the operating room is it my way or the highway to some extent. In the rest of the world, it's, life is much more complicated, of course. But there's no question, try to push my kids, to some extent, as we all do. We all want the best for them. But, you realize very quickly that there's sometimes pushing leads to the opposite result, right? And so sometimes pushing a child is the worst thing you can do in terms of getting them to, and they need to do it on their own, and you just have to figure out their personality. But I do play golf, I play music, I ski, so I have other hobbies and activities I like to do, but mostly things that won't hurt me. Like when I'm skiing, my one goal is not to get injured because, obviously you fall down and break your wrist. It's devastating for a neurosurgeon. So I'm a very safe, defensive skier. And golf, obviously, it's hard to get hurt playing golf, but, so that's a good sport for me.
And you talked about your family, and the role of the family is also quite important, isn't it? Because you could get the schedule, correct me if I'm wrong, it never gets less crazy, does it? You could still get a call late in the night or on a Saturday afternoon when you're out for lunch, let's say, with your family, and you may have to either go yourself or arrange things. So how important is the family's support for a career of a neurosurgeon, or how has it been for you? Let me ask that more personally.
I've been very lucky. I have an incredibly supportive wife and children who give me the ability to leave and do whatever I need to do whenever I need to do it. I have brought all my children into the operating room at one point or another so they can see what I do. Usually on a Saturday night, nobody's around. You're driving in at 9 o'clock to do an operation. You just kind of have them tag along. And that's been very important, I think, because then they see what it is that I do. They realize the importance of what I do. It's not some mysterious event that they feel locked out of, but they can engage in it. And that's helped them understand that the work I do is important, and that if I get a phone call at a moment of time or after I go somewhere at a moment of time, it's not because I'm ignoring them. It's because I have something else at the moment that I have to do. And I've also taken care of a lot of their friends, parents, and so they see the gratitude and the appreciation of their friends for the work that I do. And so that has helped them support me even more. And obviously it trickles down from my wife, who's just very, very supportive and allows me to accomplish everything I need to accomplish and be the person I want to be.
And from the point of view of repetition and practice, when you do certain things over and over again, that the whole concept of 10,000 hours, it probably is true more so for a brain surgeon than anyone else, is what I would imagine. But do you, at this stage of your career, when you look at your own data, say, if you have that data, do you see yourself getting better even today after having done, I think you've written that you've seen, around 2,000 tumors and twice as many brain scans alone. So that's a whole lot of work that has gone in. Is repetition an important aspect of it all?
Yeah, it's funny you mention it because I wrote a series of papers that addressed exactly that question. So I looked at my results, and I've probably done about 10,000 brain surgery operations, but of a particular type, I had done just over 2,000 of them. And I divided them up into the first 500, the second 500, the third 500, the fourth 500. And I looked at my results, and I said, did I keep getting better? And between the third 500 and the fourth 500, did I even still get better at the very end of the learning curve? And did it ever fully plateau? And the answer was that I kept getting better throughout my entire career. So even after I'd done 1,500 operations of a particular type, I did even better in the next 500. So I think that the learning curve is initially very steep in neurosurgery because you have a lot to learn. And then it plateaus a little bit, but it doesn't flatten out. It keeps getting better and better. And neurosurgeons, as long as our technical abilities are there, our brains, our judgment continues to get better throughout our entire career. So I'm still getting better than I was before, and it doesn't mean that, I was not a good surgeon before, because you could say, well, what's your cure rate for this tumor? And maybe it was 85%, and then it went up to 88%, then it went up to 90%, 92%, something like that. So, you see some incremental increase, but you still were curing a majority of patients, even when you started out, your results were very good. It's just that those extra couple of patients that you can now cure or treat or prevent from doing damage, it only has to be a couple more, in your next 100 cases, and it's a noticeable difference.
And what about calmness? You write that you also trained under a doc, and I quote, someone who had a calm pilot addressing the passenger's voice that never revealed the slightest sense of anxiety. What explains that sense of calm?
Well, not everybody is like that. Not everybody is like that. So there's some neurosurgeons who get flustered very easily. There have been neurosurgeons in the past who, throw their instruments because they get so angry. Those things are not tolerated as much anymore in the modern workplace environment, where you really have to treat everybody with respect. You can't just be a tyrant in the operating room yelling and screaming at everybody. That would not be tolerated. But there are people who deal with stress differently and can become more and more anxious. The person that one of my mentors, he happened to be particularly calm. Many of his patients were awake in the operating room. And I think when you have an awake patient in the operating room, it behooves you to really maintain your calm and your cool, because they listen to the tone of your voice. And you don't want to make them anxious. And if you sound like things are going wrong, they're obviously going to become very nervous. And you need them to participate. Because if you have an awake patient, it's usually because you're doing awake language mapping, which means that you're stimulating their brain with an electrode and having them perform language tasks, naming objects, reading, and you're trying to block their ability to speak, with an electrode on the brain. And if you hit just the right area that's important for processing speech, they'll have trouble with their speech, and that's how you know that area is critical. And so you're talking to these patients, you're asking them to do things. Sometimes you'll have them just talk about what they did that day or what they did on their last vacation, and you try to block their ability to speak. And so in that situation, you really have to stay calm. You have to make sure that everybody in the operating room is quiet. There's not so much chatter. People do tend to talk about, things. In operating rooms, it's not always so quiet because people are going about their normal days, and if there's nothing going wrong, the anesthesiologist could be talking to another anesthesiologist about, the movie they saw last night, because there's nothing going on for them at that moment.
Right.
But if you have an awake patient, you kind of really need everything to be quiet.
And do you listen to music and what keeps you calm? I've also read stories about death metal being played in the operating room. I don't know how true that is, but what's your sort of music that you like to listen to?
So I was a jazz musician by training, and so I listen to jazz, but the truth is most of the nurses do not want to listen to jazz music. And so I try to keep everybody in the OR happy. So I do like listening to music, and often I will let them put on whatever they want. So it could be top 40, it could be anything. I also like, R&B or soul music, and so I'll make recommendations, for Stevie Wonder or Chaka Khan or Steely Dan from the 70s or something like that, music that I particularly like that hopefully they'll like. But I'm happy listening to almost anything except heavy metal. I'm not a big fan.
And does anything in the human brain still surprise or amaze you today as it did? See, for example, when I read, I didn't know there was something called, what is it, grandmother's neuron or something, where, for instance, if I were to pick up my son from school, everyone's wearing the same uniform, all kids coming out at the same time. The moment I spot him, there is one particular neuron apparently that goes off. And you write a bit about that, and also the fact that if I am bilingual, if I'm being operated, you can knock off some part of the brain, and please correct me here, which will stop, where I will have no recollection of one language, but I'll know how to speak in the other, which was quite baffling.
Right. So one of the points I make in the book is that neurosurgeons have a unique window into the human brain because we have it exposed in front of us, and we can manipulate the human brain and learn about how the brain processes information. And so not only can we stimulate the brain, and as you described, and I think you did a great job describing it, we can knock out the ability to speak one language and not another language, which means that the brain will have different parts of it that are dedicated to processing information in one language and other parts dedicated to another language. There'll be some parts that are dedicated to both languages, for sure. There is overlap. I mean, people can have a stroke and have trouble with one language and still have another language preserved. But we can also put electrodes in the brain, and we can record individual neurons firing while people are doing different things. Because as I mentioned, sometimes they're awake in the operating room. So if they're awake in the operating room, you need them awake, you can use that opportunity to try to learn about the brain. And some of those experiments involved having them recognize objects. And it was discovered, as you described, that there are small groups of neurons. It may not be one neuron only. It could be, 100 neurons that will fire or increase their firing rate, specifically when you look at one unique object. And it could be one person. And if you hear their name, that neuron will fire. If you hear you hear them speaking and you recognize their voice, that neuron will fire. So it gives you the identity of that individual person, and if someone else is talking, the neuron will not fire or not increase its firing rate, which also creates the possibility, you could imagine, if we were able to eliminate all of those neurons, you would then no longer know who that person was. You wouldn't be able to identify them or recognize them. And that probably is the case. We could probably make selective lesions so that you can't recognize certain individuals. The problem is those neurons could be distributed over a wide network, and finding them and only eliminating those neurons we don't yet have the ability to do. So technically we can't actually do that, but it doesn't break any law of physics to do that. So it is possible. The other more fascinating topic, when you said what do I think is the most interesting thing, it's that if you record individual neurons in the brain that are involved in a particular behavior, and you ask someone to perform that behavior, and then you ask them to make a mental note or look at a clock and decide when they made the decision. You want them to note, when did you make the decision to do that behavior? So it could be moving your finger. And say, all right, I want you to move your finger, but I want you to look at a clock and tell me when you made the decision to move your finger. And they go, okay, I made the decision and I moved my finger. You will find neurons in the brain that will fire up to a second before they've even made the decision to move their finger. So the brain is making the decision when to do something, and then you're aware of that decision, and then you think you made the decision on your own, but really the brain probably made the decision for you. And that's also been shown in language processing, that some of the neurons involved in language tasks will fire several hundred milliseconds before the individual has made the decision what word they even want to say, which is remarkable. And as I'm speaking, I'm making the decisions what word to choose almost instantaneously. Like, it's not like I'm deciding what word to say and then I'm producing that word. It's just flowing out of my mind. But the neurons are firing a few hundred milliseconds before the words come out and before I've decided what it is that I think I want to say. And so we now realize that the brain is processing information and making decisions below the level of our conscious mind. And a lot of the behaviors we do are controlled by the brain on an unconscious level, and that we, after the fact, often make up a story and say, oh, this is why I did this. This is why I said that. Right. It makes us feel like we take ownership of why we did what we did, but often we don't really know why we're doing what we're doing and why we make the decisions that we make. We kind of make up reasons after the fact.
So is that why you also maintain that free will is a bit of an illusion as a neurosurgeon? Yeah,
well, obviously we all have the intuition that we have free will, right? We all believe in our hearts that we make our own decisions as to what to do. But when you look at data like I just described, where you have neurons that are making decisions before you're aware that you're making the decision, it makes you question whether you really have free will or not. There also are experiments that can be done where you can stimulate an electrode in the brain that will make the head turn to the left. Every time you stimulate the electrode, the head will turn to the left. And these researchers did this to a person. They would push the button and their head would turn to the left. And they'd say, well, why'd you turn your head to the left? And they would say, well, I was looking for my slippers. I thought I left them over there. Or I heard a noise in the corner. And so they didn't realize that they were turning their head to the left because they were forced to turn their head to the left. The researcher knew that. But the individual made up a reason for why they turned their head, as if they had done it of their own free will. So it may be that a lot of the behaviors we do are caused by modules in our brain that are processing information and making decisions for what we should do. And then we do that behavior, and then there's another part of our brain that basically makes up a story as to why we did the particular behavior and tricks us into thinking that we did it of our own accord, whereas really we didn't. It was some sort of a module in your brain that was processing the information and pushing you to do that. And there's more and more data that is the case out there as we learn more and more about the brain.
And does it go for feelings as well? Like for example, Dr. Anna Limke from Stanford, who's the head of the addiction clinic there, she's written good things about your book, is what I read on the blurb. She was on the podcast and she said that, for instance, a little thing like lying casually about things also changes your brain, or your wiring changes. Is that something that happens? For example, if you're late for a meeting, if you say, oh, I was stuck in traffic, when you weren't, when you were just having a sip of coffee. And if you keep doing this, obviously it becomes a habit, and we know that. But do things also change up there over time?
So every behavior you do, every emotion you have, is not only controlled by the brain and arises from the brain, but it alters the programming of your brain, because the brain is a plastic organ. Every experience you have changes the wiring of your brain. I mean, that's how memory works, right? You have an experience and you remember it because it gets laid down in the wiring of your brain. That's how you remember that. Or you practice a piece of music, over and over again, and then you can suddenly play it because you've changed the wiring of your brain. And that's true with emotions as well, because all emotions are neurons firing, and all we are electrical impulses in a sea of chemicals, because there's also neurotransmitters that are passing from neuron to neuron, and those neurotransmitters can hit receptors where you can have more receptors or less receptors. You can have more neurotransmitter released, less neurotransmitter released, and that's also part of the learning and wiring process. So we know that we can alter the brain with surgeries or by placing electrodes in the brain that can change your personality. We can take people who are obsessive compulsive and, eliminate or moderate their feelings of obsessive compulsion. There's a famous case I wrote about of someone who had a stimulator in his brain and suddenly enjoyed the music of Johnny Cash that he never enjoyed before. We have treatments for depression as well, where you can put electrodes in the brain in a person who's horribly depressed and can't get out of bed and doesn't enjoy anything in life, and suddenly they have motivation and they begin to enjoy daily activities merely from an electrode being activated and stimulating a particular circuit in their brain. So we're just at the cusp of understanding all of this, but we have the ability to modify human taste, human behavior, human judgment based on altering the wiring in your brain, whether it's through chemicals or through electricity.
I remember watching Boston Legal long ago, where there was this lawyer who's defending someone who people want that person to fail. And he says Schadenfreude, which is damage and joy, German, where you seek a spiteful, malicious delight in the misfortune of others. And he says that in 2004, and I looked it up, apparently it's true, that a neurosurgeon from Stanford actually captured this in a brain scan, where when we see others fall, it causes some chemical to be released in the dorsal striatum of the brain that causes us to feel pleasure, which is, so basically everything can be, you said personality. Do you, for example, when you talk to people, you say, this guy must have this thing firing in his brain? Or, does that happen anytime? Can you guess what's happening up there by looking at people's personalities?
The answer is yes and no. So yes, whenever they do anything, I know that it's something firing in their brain, because that's the only reason we do anything. On the other hand, I don't know where exactly it's firing, right? We don't understand exactly how the brain codes for everything and what it does. So I can't tell you exactly what part of the brain is firing at that particular moment in that individual, but there's no question that all our behaviors, all our decisions arise from the neurons in our brain firing in particular patterns and sequences.
The last question is with respect to your writing. You wrote this book within a year, if my memory serves me right. And how was the process of putting this through? There is enough secondary research available out there. I mean, there have been books on brain. What was your decision, and how did you go about it? And is there any correlation between neurosurgery and writing? Was it easy or difficult to make it simple for us?
I love the process of writing. I enjoy sitting down and writing. So for me, it was a pleasant experience. It's very relaxing for me. We talked about ways in which you detach from a stressful job. So for me, writing about it was therapeutic. It did take about a year for me to get it done. And the reason I thought it would be interesting was I thought I was trying to tell a different story than had already been told out there. There are some really good books written by other neurosurgeons that tend to be memoirs where they're writing about their patients. And I did a little bit of that, but I wanted to really write about the field of neurosurgery, sort of in a historical way, but not really to be a dry history of neurosurgery, but to try to make it a living history of neurosurgery, somewhat through cases, somewhat through my own experience, and then also using the stories of famous politicians and celebrities and sports figures that we all know who had brain surgery, so that as a average reader, you'd recognize them and you'd be interested in their story because you know who they are and you kind of knew that they had something that happened, but you don't really understand what happened. And then I can use that to open up a window into why did the neurosurgeon do what they did and what does that mean that it was done that way and who did it first.
And this is Gray Matters, a biography of brain surgery. Thank you so much, Dr. Schwartz, for your time on this podcast. Thank you. This was fun.
Abhishek, thank you so much. It was a pleasure talking to you.
Thank you.
Take care.